Join our YouTube channel to learn surgery in a simple way.
This is a highly simplified diagram of hepatoportal system, which I will use to explain the concepts of various shunt surgeries. All venous drainage of gastrointestinal tract is not allowed to enter systemic circulation directly, as blood coming from gut can have lot of toxic wastes and compounds absorbed from food and produced by gut bacteria. These toxic substances must be filtered and neutralized by liver before sending into systemic circulation. Hence, all blood from gut goes to portal vein to reach liver. What happens when there is obstruction in the path of this portal flow? This can be in portal vein, like portal venous thrombosis, or in the parenchyma of liver, like in cirrhosis, where fibrosis occurs in liver parenchyma. These fibrotic bands can compress and occlude portal venous branches in liver and hence obstruction to flow. Or there can be obstruction of hepatic veins by thrombus or stenosis or suprahepatic IVC obstruction, Budd-Chiari syndrome. All these processes have an end result of increased pressure in portal vein, which is called portal hypertension, due to pooling of blood in portal vein and continuous arterial flow coming to gut. Pressure increases and this pressure transmits back to gut, leading to venous congestion of gut wall. Increased congestion with time leads to extravasation of fluid from gut wall causing ascites. Increased pressure in portal vein leads to opening up of veins, which connect portal and systemic circulation in fetus, but serve no major important function in adult. These vessels, most notably at both ends of gut, gastroesophageal junction and around rectum, dilates. But these veins are not strong enough to hold lot of blood and so as they dilate they become thin-walled and become prone to rupture. These are called varices. Thirdly, due to shunting of portal blood to systemic circulation through these natural shunts, toxins coming from gut directly enter circulation and are toxic to tissues, like ammonia, produced by gut bacteria which are converted to urea in liver, is now entering circulation and affects neurotransmission in brain leading to encephalopathy. So the purpose of shunt is only to decrease the pressure in portal system. Most classic shunt is portocaval shunt, in which main portal vein is either cut and anastomosed to IVC, end to side, or portal vein is not cut but joined to IVC side to side. These were earlier called as ex fistula. It is very effective as controlling variceal bleed and ascites, as whole portal system drains into low pressure IVC, but as you see toxins will reach body tissues and so encephalopathy increases. Most encephalopathy occurs in end to side shunt, where no portal blood is going to liver to purify and slightly less in side to side, where some portal flow is maintained. Another disadvantage of portocaval shunt is that the dissection is done at porta, which makes future liver transplant difficult, as we need to preserve porta hepatis anatomy, so these portocaval shunts are never used if transplant is anticipated. There is one way in which same effect of portocaval shunt can be achieved, without disturbing anatomy of porta hepatis, thus allowing liver transplant. That is mesocaval shunt, where shunt is done slightly inferiorly between superior mesenteric vein and IVC, with help of a vein graft. Same control of varices and ascites is achieved, but transplant is feasible. However, problem of encephalopathy remains, obviously. So a shunt was needed which could decompress only variceal bleed, and allow significant blood to liver to continue. So shunt was shifted to splenic vein. Now shunt is done between splenic vein and renal vein. Since splenic vein is away from IVC, so renal vein is chosen for shunt, as it is adjacent and almost parallel to splenic vein. In any vein, proximal and distal is labeled as per direction of flow. So in splenic vein, proximal area is near spleen and distal is away from spleen. Proximal splenic vein is cut and joined to left renal vein in end to side fashion. So now spleen has no venous drainage, so splenectomy is done. This is proximal splenorenal shunt. Portal flow decompresses in renal vein and some flow to liver is also maintained. Since portal flow is decompressed, so ascites is relieved. Left gastric vein, also called coronary vein, along with other gastric and pancreatic veins, are ligated to prevent transmission of portal pressure to esophageal and gastric varices. Disadvantage is that splenectomy needs to be done, increasing blood loss, A surgery in portal hypertension case becomes difficult due to various collaterals. This shunt, however, is advantageous where there is hypersplenism also. Now a shunt was planned which could decompress esophageal varices, but without any need of splenectomy. This was achieved by anastomosing distal part of splenic vein to left renal vein keeping spleen intact. This does not decompress portal system, so ascites is not relieved. Instead ascites may get aggravated, as during surgery dissection may disrupt lymphatic routes further increasing ascites. This shunt selectively decompresses short gastric venous system which causes gastric varices. Left gastric vein, also called coronary vein, along with other gastric and pancreatic veins, are ligated to prevent transmission of portal pressure to esophageal and gastric varices. Since distal splenorenal shunt, also called Warren's shunt, selectively decompresses varices, so it is called selective shunt. Rest other shunts discussed above are non-selective shunt. It was thought that if diameter of non-selective shunt is decreased, then there could be similar effects on varices and ascites, but with less chances of encephalopathy. So next shunt between portal vein and IVC or mesocaval shunt were planned, but using a conduit with diameter less than 8 mm. These shunt are not selective, but preserve flow to liver by diverting less amount of blood to systemic circulation, enough to decrease portal pressure. Hence these are called partial shunts. Shunt surgeries are now rarely done, and if needed, an interventional minimally invasive approach is done wherever there is requirement of shunt. This is TIPS transjugular intrahepatic portosystemic shunt. In this procedure, hepatic vein is cannulated via jugular vein and a catheter is passed through liver parenchyma to a branch of portal vein and a stent is placed, causing a portosystemic shunt effectively. TIPS does not disturb portohepatis anatomy, hence transplant can be done. In fact, TIPS is procedure of choice in patients awaiting transplant.
Join our YouTube channel to learn surgery in a simple way.